So this past winter, I was asked to speak on the topic of addiction. It's a topic I know well. Worked in it as a CEO of the local agency for the last 10 years. And I have my own struggle with mental health and addiction. And so the original talk I was going to give you really focused in on that. I know how these talks go. You hear a little bit about my background with those struggles. I tell you some anecdotes about crashing a car, spending a night in jail, about living in Chicago in my 20s, running from pain, waking up next to women that I forgot meeting. Actually, in my case, more honestly, it was waking up with half-eaten burritos that I don't remember buying. But since that time, that was 5 months ago, and the world has changed. And so the context of my talk changed. We've met a pandemic that has completely changed the world. So I spent the last 10 years of my career running up and down the halls of our state capitol and even Washington, D.C., yelling fire to anybody that would listen to me. And not that we've been traveling lately, but had I been in those halls now, I don't think I'd be yelling fire. I think I'd be politely opening the door and saying, "Come on in, coronavirus. This is your time now. We need to figure you out. Oh, excuse me, Black Lives Matter. Didn't see you coming, but I should have." So in the matter of a number of months, this pandemic has halted our world economy, devastated millions of lives, and has the world scientists working on cure and treatment. Then just a few months later, the Black Lives Matter movement comes to fruition and is right now the largest social justice movement in the history of the world. That's all just happened, folks. And so, how do I talk about addiction when this was the most important public health crisis in our country in that context? And we see that those public crises are having effect. We see what's happening in science, and we're going to figure this out. We also see with the Black Lives Matter movement, things are starting to change, some really odd things. NASCAR banning a Confederate flag, Elmo talking to our kids about the protests. But the most significant thing that's happened, I think, in my mind, relative to this, is that we've named these things, in particular racism and systematic racism, a public health crisis. Cities across the country are naming that a public health crisis. And I think that's significant for us as healthcare professionals as we think about rethinking health. We've now elevated that to a status that matches HIV and AIDS in the 80s, suicide, gun violence, and yes, addiction. Because I think one thing that we have seen through both of these pandemics is that health outcomes for folks of color are horrific. And I think for a lot of Americans, for the very first time, we're seeing an impact of that disparity on people of color. And it's not just COVID. So in the state of Michigan, with 14% of the population being black, 40% of folks dying are black. And that's not just about COVID, that's about those underlying conditions that are complicating the mortality rates for COVID. So it is a public health crisis, regardless of political. I know this is a hot topic, and but it is a public health crisis. And so that brings me back to a little bit of where my talk was to talk about public health crisis and what is a public health crisis and what is a public health strategy. Well, the public health strategy first really is naming a thing, identifying a thing so that we can get our head around it and put strategies in place to make sense of that thing. And that thing is something that we've identified as having a significant negative impact on a population. So I know that I know that well for the field that I work in. And so we also look at, if we look at these two new epidemics, the COVID-19 pandemic, that's a little clear to understand from a public health strategy. We have scientists working on the issue. We have treatment, vaccines. We know to wear our masks. We know about hand washing. Yesterday I just read I better shut the toilet lid now to mitigate the spread. So we're learning. That's a public health strategy. That's clean. We understand it. Racism, less so. That one's pretty messy. And again, I acknowledge that that is a messy topic. But by definition, it is a public health strategy. And that's significant because the way we need to think about public health strategies is that they do not live in isolation. They are not strategies in isolation. They cross, they intersect. So if we take there's a public health strategy in this country around obesity, where a third of Americans are obese. And the work that we do there affects other public health strategies like diabetes, which is another crisis in our country. And those interplay with each other and have positive effects on other things like blood pressure. So it's important to bring it up, I think, and to acknowledge that addiction is one of those public health strategies. And why I think it's important is because it's really hard to talk about addiction and how we manage addiction in this country without acknowledging the negative impact it's had on people of color. But I think the other reason to talk about it is that for the first time in 40 years, which is essentially the time frame of our field, we believe, I'm an optimist, I think we are on the cusp of not only, now that we've identified a public health strategy, but that we are actually going to implement that public health strategy. We're inching closer to it in addiction. But it sure feels different now. We're wondering whether we still have the right, even, to have this conversation, and whether we have enough wind in our sails to get done and further the work that we already have. My field's an interesting thing because we have lots of opinions. I was leaving work the other day and somebody, I was a little disheveled and said, man, this is tough work right now. And, I got let's fake it till you make it. It's a popular adage. I've been told that because I'm not involved in a 12-step program that I'm not really in recovery. We have folks that believe that if you take a drug to help a prescribed drug to help your addiction, that you're not really in recovery. Folks have their own pathways and they believe in those. And we mostly allow for that. But one thing that we've really done in the last few years that I think I'm proud of is that we have really honed in on that definition of what a public health strategy is for our field. And so I want to name what those are. We understand now that the neurobiology of substance use, misuse, and addiction. We understand that this is a brain disease. The science is clear, the evidence is there, we know it, we understand it. It's not for debate. We know that prevention programs and policies work. We can keep people from getting addicted. We know that, we have the evidence, and we've agreed on that as a collective. We know that early intervention and treatment are possible. So if somebody does become addicted, we do not have to wait for them to get really sick. We can have early intervention, and that we can have better treatment, and that when they post-treatment, we can help people and manage them. We can do that, and that the data shows us that. That there's many pathways to recovery. There isn't just a singular way. And that the healthcare system and substance abuse system have to work in concert with each other. We realize that now. For 40 years, we essentially said, as a field, we got this, we'll take care of our own, we understand this. But the fact of the matter is, despite the focus on opiates right now, and the opiate epidemic, which is a sub-epidemic of our addiction epidemic, addiction rates have not changed in this country in those 30 years. We are still as addicted as we ever were, despite seeing some gains. Yes, more people are dying because the drug of choice in this moment is opiates, and that's devastating. But we have an addiction epidemic. So I say that for two reasons. The first is that I don't think that some of that probably jives with folks, our common understanding of what addiction is and how we treat addiction. And folks listening to this might not get that. But the leaders in our field and all the data says that is our public health strategy. I didn't make that up. That is what our strategy is. That is what our goals are. And we've been working towards that now for a number of years. Assume I take a bite out of an apple and I hold it to you and ask you to describe that apple. You're going to describe red, shiny, but that's not my reality looking at it from this side in the bite. And that's what this field, and I'd say our new public health, the caution for our new public health crises that are joining us, is that both realities are valid. But how do we get to see that whole apple? How do we value that both of those perspectives are true? We go to our elders, we go to our scholars, and we go to the data and the science. And so we have to admit that our field is lacking the data, but we're doing some good things. We're starting pilot programs where we can learn from each other. We're getting funding from the feds to implement strategies that make sense based on those public health strategies that I talked about. And that's good stuff. Our little organization is an opiate health home. So we're actually doing primary care for folks that are struggling with addiction. And that is significant. That is something we wouldn't have conceived of a number of years ago. But the system we have isn't reflective of that. And the reason for that, in other words, the system that we have in place does not reflect that public health strategy yet, even though we're inching towards it. And that's because of stigma. That's because of the biases that we have. One of them is this notion that folks need to hit rock bottom, right? We know that everybody, it's hard for us to think that isn't the truth, but it isn't. In fact, it's inhumane, it's disgusting, and it's wrong. It allows us to justify oppression. It allows us as healthcare professionals to wait and watch as you get sicker. And then for some people that haven't died, we'll catch you and we'll help you. We won't give you any aftercare because that doesn't exist. So agencies like mine can't get assistance in really helping folks throughout that disease process. Another bias that we have is that relapse is devastating. We've seen the slow-mo videos, or the movies, right? Is he going to take that final drink after the hard day? He's been in recovery for 6 months. And we judge when that happens. I just watched a movie the other night where that was it. Most folks relapse. This is a chronic relapsing disease, but our system is built around not having those systems in place. If we had more early intervention, we had more prevention, we had held people in a path of recovery, we would have less death. We know that. Again, the data is there. The criminalization of addiction is another just devastating reality. There's nothing in our strategy that says addiction is a crime. We understand where this narrative came from in the war on drugs, but that has been one of the largest public health failures in the history of this country. And unfortunately now, the result is that the largest system that manages our mentally ill and addicted folks in this country are our prison systems, by far. Which brings us to my last point, that this is a moral failure of some sort. This is a character deficit, that folks struggling with addiction are somehow defective. We know that's not true. The science tells us that's not true. The data tells us it's not true. But our systems don't allow for that. And so I mentioned the intersection between diabetes and obesity as a simple, clean intersect. But there's also an intersect between what's happening in the world right now and addiction work. So why I question what's our role in this, I challenge our profession that this is the moment. The world is upside down, and it's not going to, if you listen to this talk 5 years from now, this is going to have relevance because this is not a quick moving train. When we look for those intersects, just think about what we could do in our field that would have an impact on what we're seeing. What if instead of calling the police on an intoxicated person, instead somebody that looks like me as a social worker shows up there, and a first responder, and we with mental health first aid, and we get some folks some help? What if we didn't have local judges that would put people in jail for taking a prescribed medication by their doctor to manage their addiction? That's disgusting, but we allow it to happen. What if our local hospitals didn't defund behavioral health programs, but understood the public health impact that a robust behavioral health program that treats mental health and treats addiction will have on public health? But we're seeing just the opposite happening. What if we tended to the trauma of all people and understood that poverty, understood that abuse, understood that unstable homes are trauma, and we built systems to help folks manage those? As Desmond Tutu talked about, let's stop picking people up downstream and figure out why they're falling in the first place. What if we embrace harm reduction strategies that build systems to reduce people's harm, or even better yet, that we build systems that don't cause that harm in the first place? What if we agreed that life has value and that we need to treat people when they're struggling? We need to identify that. What if we didn't automatically keep drug users from voting? What if organizations like mine were empowered to do early intervention and to do after treatment so that we could keep people out of the system, my system, instead of incentivizing that they embrace my system and come back to my system and we wait for you to come back? What if we educated the public about the things I talked about, what addiction is and isn't? It would change our whole narrative. Because what we believe about a thing is the start of how we politicize it and how we build interventions around it. So that belief system has to change. And we are at a moment in time where we're defining that. We have a path, we have a plan in our field. The public health crisis of systematic racism, there's no plan yet. But we understand that the things that we do in our field, this is a call to action. This is a once in a generation, once in a lifetime opportunity as the world is upside down for us to step in and make a positive difference. And that's not an understatement. I believe that strongly. We have an opportunity to have a public health impact that is like nothing we've ever seen before. And I'm not trying to give you an exhaustive list. Those are just examples, and those are examples of things that are already happening that we're learning from. So they're real. And if you don't believe the intersect of addiction and what's happening right now in our world, let's go back to the murder of George Floyd and what the other officer said during that time to the crowd of onlookers. Don't do drugs, kids. This is a moment in time where we get to redefine what healthcare looks like and what addiction care looks like in our field. And for the first time, I believe, ever, we can say that the disproportionate impact that this has on the people of color is a good thing. So I hope we can seize this moment. Thank you.